May I request Chandni to introduce Dr. Govindaraj? Chandni is a second year MBBS student and she's a multifaceted personality, a good public speaker, a professional oil painter. Vidya, you have a lot of followers here, and a state level basketball player. She wants to be an oncologist in the future. Over to you, Chandni.
Good afternoon, everybody. I take immense pleasure in introducing Dr. A.B. Govindaraj. He is an orthopedic and joint replacement surgeon who has worked in various renowned institutions in Chennai. He did his MBBS from Tanjore Medical College. He trained in orthopedics and joint replacement surgery in the UK. He is a fellow of the Royal College of Surgeons. Dr. Govindaraj has over 40 years of experience in his field and has performed over 10,000 surgeries, including 3,000 plus joint replacement surgeries. He is currently the Director of Orthopedics at MGM Healthcare, Chennai. Apart from all this, he's a great fitness enthusiast and enjoys playing squash. Once again, with immense pride, I would like to welcome Dr. A.B. Govindaraj to give us more insight about his inspiring 40 years of journey and experience in this field.
Good afternoon, friends and colleagues. I'm basically from Kadalur, so in a way I'm a son of the soil for this area. I didn't study in MGM, but I studied in Tanjore Medical College as I was introduced. So today's topic is about what's new in joint replacement, particularly knee replacement. I'm basically a knee replacement surgeon, so I'll just cover mainly the knee replacement aspects. So traditionally, we've been taught that the knee is a hinge joint. It's nowhere near a hinge, really, because it moves in so many different directions and there's so many other movements. So, like Dr. Sridhar and Dr. Sharif had mentioned, we needed to relearn anatomy and physiology. So, the knee moves in a variety of directions, not just the hinge. It rotates, it slides anterior posterior, it slides mediolaterally, and it even telescopes. So we didn't understand this in the earlier days. So the joints were designed like a hinge, and they all failed miserably. When I started doing my joint replacements about 40 years ago, assisting during my practice, they were all hinge replacements, and they all failed miserably in 2 to 3 years' time. Every day morning we'll be doing a primary, afternoon we'll be doing a revision. Not for the same patient, of course, the ones that who had it 3 years ago. So it was a miserable situation. So over time we found that the knee is not a hinge joint, and then we rectified. So that is an advancement. So advancements need not be in terms of artificial intelligence and robotics and other things. It should be in the basic understanding of the process, the anatomy, the physiology, and the biomechanics. So, I mean, I don't have to bore you with the overview of a knee joint, but this is how a normal joint looks like. And the right side is the affected joint. We get arthritis as we get older. And of course, for a variety of reasons, we all get arthritis, and we might need a knee replacement surgery. So the primary way of finding out whether you have arthritis, whether you need knee replacement, is by doing X-rays. And once you diagnose and you recommend a knee replacement is required, then the next question is when do you actually do it? Because a lot of people say, do I have to do it now? Is my X-ray ready for knee replacement? So the answer is not there in the X-ray. It's in what you are experiencing and what difficulty you're undergoing and what you want in life. So a lot of things are changing. Like those days, we just look at the X-ray and say you need knee replacement, and then they just went for it. So it's patient driven, and if the patient needs it, then we recommend it. So what are the other effects of the knee replacement? What happens after knee replacement is important. So that decides whether the patient wants to go for it now or wait for a little longer. And so we need to really explain and make them understand the need for a knee replacement. So before we go into advances, we first want to know what is a traditional knee replacement. Basically, it's an 8-inch long incision, and we subluxate the tibia anteriorly and remove the damaged portions, cut and remove. We don't actually remove the entire knee and replace it. We only remove the surface of the knee which is damaged, and we replace the surface with an artificial implant. So once the artificial implant is put into place, if it's done properly with the appropriate materials, it should last for about 20 to 25 years with the current technology that we have. So this has been the traditional knee replacement we have been doing for the last 25, 30 years now. And it's been pretty successful. I would say the 20-year success rate, survival rate of the implant is about 90%, which is pretty fantastic. So 90% of the patients are still walking on the original knee we put in 20 years ago. Of course, 10% fail and they need revision for other reasons. It could be infection, it could be loosening, or it could be a fracture, or it could be so many other, imbalance, instability, so many other reasons. But the ones that have been put into place correctly will last for about 20 years. So how quick is the recovery? Because we need to know again what are the advances in the recovery time. Now everybody is talking about daycare knee replacement or fast track knee replacement. So traditionally people come in for a single knee. They come in, stay a day before and stay for four days after the surgery. And when they go home, they walk up and down the stairs independently, and that's the way it goes. But for bilateral, which I mostly do both knee replacements at the same time, and they come in day before the surgery and go home 5 to 6 days later, again walking up and down the stairs independently on the 5th or 6th day before they go home. This is for 90% of the patients. The patients who are very unwell and they cannot do that, but they might take a few days extra. So this again has been achieved by a lot of improvements over the years. Before, when I first started, they were all in hospital for 2 full weeks until the removal of sutures done, and they didn't walk really comfortably until about 2 or 3 months later, because the technology, the rehab, everything was very, very slow. Now people are able to walk mostly on the same day, or if not the next day of the surgery, and continue to improve over the next few days and go home in a few days, depending on whether it is one knee or both knee replacements. So the surgical approaches, again, understanding of the way we approach the knee joint has improved over the years. We've been traditionally doing the paramedian and then the subvastus and then the midvastus approach. So everything adds to the speed of recovery and also the time spent in the hospital and the longevity of the implants. So I saw a nice poster outside with all the recent advances, and now we come to the advances. Away from the traditional surgeries we've been doing. So as time went, we also evolved, and the minimally invasive surgery concept came in. So what is it exactly? It's a small incision, or is it more than that? If you see the scar on the left side of the left knee of the patient, she had a traditional knee replacement, and the right side was a minimally invasive. Yes, it is a small scar. It's not just a small scar. The way we approach the tissues inside also changes. The instrumentation is different. They are much more sleeker, and they have different instruments which will make us do smaller exposure, thereby speed up the recovery and return to home, return to function, return to sporting activities. All those things can be achieved by minimally invasive surgery. So again, it's now slowly the incisions are shrinking gradually, and most of the times we're able to do minimally invasive, except in patients where you have very unstable knees, where you have to do ligament release or reconstruction. Then it has to be a bigger conventional knee replacement. Patient-specific implants. So when we had all this scores settled, younger orthopedic surgeons came into the field and they want to do something different. They had to invent something, otherwise it's too boring. So they came up with something, what can you do better than what we already have? So they said, why should we put the same implant for all patients? I mean, there are only 2, 5 or 6 or 7 or 8 sizes. And it's like you go to a ready-made shop, you buy a shirt or pant, as against get it stitched by a tailor. It fits your size. If the tailor is good, then you get a fantastic deal. So this is the concept. So you give patient-specific implants. You take the CT scan pictures of the disease joint, and you create a model, and you tell the model to create a set of instruments to cut the bone, and also you can 3D cut the implants, and then you can implant it to them. It's an overkill. I think it's probably too early in the evolution process for this to be successful. So it's being used and tried, but it is not very popular. It's very expensive, and it is really not affordable. The advantages of this technology has not been changing the way outcome has been expected. So it is not taking off in the way that they all expected. I don't do this because it's too expensive, and my patients can't afford it. So what else can you do to revolutionize knee replacement surgeries is to bring in the robots, navigation robots. So first, about 10 or 15 years ago, navigation came in. What is navigation? Basically, it's a very complex surgery to do a knee replacement, to balance, to cut the bones correctly, and to balance the ligaments, and to give a stable joint which can last for 20 years. It's an art, and you need to really learn it. It's a long learning curve, and so to make that learning curve shorter, people introduced navigation. Navigation basically tells you how much of bone to cut, how much of polyethylene to be inserted, and various guides to the various steps of the operation. Again, it was too cumbersome because you had to put all kinds of metal into the bone, and you have to really depend on the computer. A lot of times that it's like using Google 20 years ago. You can suddenly end up in the middle of nowhere when you should have been in the McDonald's shop or something like that. So it was not good, and slowly it died a natural death. And then the second generation of navigation came the robotics. Robotics use navigation and also cutting instrumentation incorporated into the arm, the robotic arm. So it's basically robotic assisted, not robotic knee surgery completely. So they assist the surgeon in doing the cuts and balancing the knee and producing a better placement of the implants. Yes, it has definitely improved the overall X-ray appearances of the the patients after the surgery, but that has not really been translated to good results in terms of better outcome or pain-free knee or enjoyable knee, as they call it. So it's only increased the cost and increased the learning curve of people. It's being studied. I hope in the long term it will all help you. When you all become surgeons, it will probably be better and easier and cheaper to use, and that will be the time I think that they will have the day. I'm sure that day is not very far off. So there are varieties of robotic arm. You can use it for as a passive or semi-active or active assistance. Each company has got their own concept, and so they make it according to that. And of course, navigation is on its way out, but navigation is being incorporated into the robot to help you to do the surgery more efficiently. So another area of improvement is the post-surgical rehabilitation. So one of the reasons why we're able to send them home early is because excellent rehab. We just don't send them to physiotherapy. We tailor-make individual patients depending on their various deformities and their requirements and their heart condition, renal condition, various other, the age and other things. We tailor it, and there are fantastic new equipments. The pain management, like Dr. Vidya knows, starts before surgery, at surgery, and after. So we give intraoperative blocks, immediate postoperative blocks. We use cryotherapy, we use equipments to speed up the rehab. All this has definitely contributed to the overall outcome, patient-centric care, and improved implant durability. The material used for the implants is getting better and better over the years, and metal and polyethylene are the main ones. Cobalt chromium has been the standard equipment for implant manufacture because they are particularly for the knee in combination with titanium. Now, slowly, ceramic is creeping in. People sometimes are allergic to the metal, cobalt chromium. So these patients, sometimes we have to offer them the choice of ceramic. Ceramic implants are again expensive and also brittle. So to overcome that, they have started doing the titanium implants with various coating of ceramic pellets. They blast it at high temperature into the onto the titanium surface, make it harder and also not brittle. So zirconium is another thing which is slowly getting popular. It's again only for people who are allergic to metal like cobalt chromium. Polyethylene has transformed again from Teflon to polyethylene to ultra-high weight polyethylene, cross-linked, and vitamin E infused polyethylene. So they have really come a long way. But sterilization is a danger zone where if you don't use proper sterilization technique and the shelf life comes down, and there are a lot of recalls. Only recently we had a recall. After putting it and the patient's been working on it for 5 years, the company says that it's a faulty polyethylene. Can you tell all your patients if they have a problem, they can come back and have an inquiry? That's a very dangerous situation to be in. So better to be very watchful before you jump into any new technology just because it looks colorful, it looks flashy, and they're making a lot of sound noise about promoting it. Be very, very careful. Test each one of them. See your colleagues doing it, and see the results before you start doing anything new, anything different. Of course, 3D printing in metal has started. I feel right now it's just more fashion than reality oriented. Smarter inventory solution where you don't have to keep too many sizes. You can really order them just before a few days before, and faster medical imaging because it takes a long time to register and to start the surgeries. All those things will come. It's in the process, but I think it's just a matter of time before that hits the market. The other thing is a smart knees where they carry a sensor. The little stem downstairs down has got a sensor. It keeps beeping, sends you information to the telephone of the person who's monitoring, the team who's monitoring, so it can tell early signs of loosening, whether the patient is doing enough or patient even sometimes had a fall. So many other things can be picked up by these technologies, but they are all still very experimental, and I'm sure it will see the light of day very soon. That's my last slide.
Yeah, ABJ, just one question.
Yeah.
See, I thought whatever things which you don't use are preserved. Right. When you're not using knees and resting them, why should they get damaged? Seriously, now if I overuse only, going to get spoiled.
No,
If I
no.
preserve them, they'll be pristine.
See, last week I picked up a battery for my thing. They said use it every day, otherwise it will conk out. If you overuse it, everything has got a kind of a way it has to be used. See, the problem with thing is people think if you use it, it's not a chapel to get worn out. It's a biological tissue. It's not the joint which is just put to use. When you use your knee joint, your muscles, your ligaments, your entire body, your heart, everything works, and they need to be conditioned and kept in certain amount of base throttle. Otherwise, if you don't use it, everything gets rusty, everything gets atrophied, everything gets wasted, and then suddenly you want it, to want to put it to use, it just won't crank up. So you have to use everything moderately. Be sensible. Don't climb 20 floors every day 5 times. Some people are doing that, but you just be sensible.
Yes.
Now,
Thank you.
what is the role of regenerative medicine? How far has it advanced, especially in the reconstruction of the knee joint?
My opinion is it's still a hoax. A lot of people like the PRP and various things. I mean, it's good in certain small areas where you have a small patch of cartilage missing in the thing. Like osteochondritis dissecans is a condition where a small patch of bone just falls off because of osteonecrosis, because of blood circulation problems. So in that case, you can take culture the chondrocytes and you patch it up and it works. But you can't do that for arthritis. Arthritis is a degenerative disorder, has developed over a period of decades, and you have underlying problems which are causing it. You can't go and patch up an arthritic knee with chondrocyte implantation. So that's where it's all being abused. So what reason it was introduced or it was brought into the market, it's not happening. It's doing for other things. The regenerative medicine is a lot of things like PRP is the biggest joke, and I use it because some patients insist on it. They read on the internet. Their son in the USA, a daughter in Singapore, some says you go and have it. So I try to explain to them. I have other methods, non-surgical, non-invasive methods, which can improve your lifestyle by exercising. I have fantastic rehab exercises which literally does miracles. But they try that and sometimes they just got it in their mind. They want this little injection. I give it to them. I tell them. And then there are other, synovial fluid replacement. Of course, we start off with the steroids those days. It still works. We have PRP injections, we have this synovial fluid injections, the various autologous chondrocyte, cultured chondrocyte. So these are all things for specific problems, not for arthritis. And bone stem cell, all those things are all for sometimes used for certain localized special problems, not for arthritis. Yeah, partial knee replacement is another hoax. I'm sorry to keep using that word because the average life of a partial replacement or a partial replacement meaning one half of the knee, which is the one mostly affected, the middle side is mostly affected, 90% of the patients. So if you are only replacing that, it'll last you for about, the total knee replacement average life is, I told you, 20 years. The partial replacement is about 10 to 15 years. So if you're going to do a partial replacement and when it becomes loose or problematic, you can't just remove it and put a total hip replacement. It becomes a revision. Okay, a revision, whether it is a unicondylar revision or by total hip revision is a revision. You have to go through the same process of resecting a lot of bone and putting a revision stem which has got a little extra long stem. And so so in my opinion, if somebody needs a unicondylar, you put them on other measures and try to avoid surgery in the first place. If that's not going to work, then just offer them a total hip replacement, total knee replacement.
As usual, Dr. Govindaraj starts and finishes on time. So, may I request to do the honors, please.